On to Vermont, Ina Backus. Can you also talk about what Vermont is aspiring to and what it's done and what that means for the health of people in Vermont?
Absolutely. Thank you. Vermont is moving on a statewide basis to pay for health and well-being rather than paying for each individual procedure and visit. And we're doing that through a partnership with the Center for Medicare and Medicaid Innovation at CMS, just like Donna and her team previously in Maryland, and Maryland is today. And I should say that there are just a few of these state models in partnership with the Center for Medicare and Medicaid Innovation. And we certainly looked to Maryland and their expertise and their long history working with Medicare in payment models on a statewide basis to help inform Vermont's model. As I said, we're moving away from fee-for-service on a statewide basis to a value-based payment model with the intent of moderating growth in healthcare costs, improving quality and experience of care, and improving population health. In this model, we're including a suite of services, a set of services. Our total cost of care is how we refer to it, that is roughly equivalent to the services that are provided as a part of Medicare Part A and B plans, with anticipation to look at additional Medicaid services coming into the total cost of care in future years beyond the initial demonstration. So it's a broad and encompassing set of services for the state of Vermont in this model. We're looking to include the majority of residents in the model by the end of the performance period that we've established. We're in performance year 4 now. This is an area where we have more work to do and where we may not reach our targets, but that we do have more than 50% of our, or excuse me, just about 50% of our population in the model at this time. The model is also intended to limit per capita healthcare growth so that that can be better aligned with our state economic growth. Our state economic growth is not as robust as we would like it, but the delta between it and healthcare cost growth has been larger than it should be. And so the model is intending to bring healthcare cost growth more into alignment with our state economic growth. The model is also aiming to improve population health outcomes, and to do so by increasing access to primary care, decreasing deaths due to drug overdose and suicide, and reducing the prevalence and morbidity of chronic disease. These population health outcomes goals reflect goals that had been established through a process in Vermont, our State Health Improvement Plan. That's a plan that our Department of Health convenes and puts together on a regular basis, and that we use in the state of Vermont to drive towards better outcomes on a statewide basis. I think it's one of our signature innovations in this model that we are committing that payment change is also a lever to improve our population health outcomes, in addition to those population health strategies and public health strategies that we would typically think of in our state. We're in this model aligning the significant payer programs for ACOs in a value-based payment and care model. Our model is called the Vermont All-Payer ACO Model. And so the payment change, the value-based change that we are driving is one that is realized through an ACO model. We happen to have only one accountable care organization in the state of Vermont. It is a statewide organization. It has a network that is comprised of a very diverse set of providers. It's not what people would typically think of perhaps as a physician-led ACO or a hospital-led ACO. This ACO encompasses the large majority of hospitals in our state and independent practitioners, both primary care and specialty providers, federally qualified health centers, our network of home health providers, skilled nursing facilities, as well as our state designated mental health and substance use disorder provider agencies are examples of providers that are in this network. And there are more than 160 different organizations that are participating in the OneCare Vermont ACO. Our model didn't say that we had to only have one ACO. The model wasn't designed to be a single ACO model. However, in a state the size of Vermont, there are certainly advantages to the type of coordination that the ACO in Vermont is able to facilitate. However, there's no prohibition on other ACOs if they would be interested in participating. We're aligning the payment program for ACO in the Medicare program, and we're able to do that through our relationship with CMMI, aligning that as much as possible with Medicaid participation in the program, as well as commercial payer participation in the program. The ACO model in Vermont is able to build upon and leverage some existing both population health and also primary care foundation in the state of Vermont. Vermont, through a program called the Blueprint for Health, has a long-standing patient-centered medical home program that is a foundation for the work that the ACO is doing to try to drive population health. That patient-centered medical home program is paired with community health teams. Those community health teams extend and provide supports out into the community, can drive towards addressing social determinants of health, and are also a key component in Vermont's hub and spoke model for treatment for opioid dependency. And in particular, the spoke component of that model is one that's happening in patient-centered medical homes that are supported in providing medication-assisted treatment and wraparound services and supports. And finally, we have a care coordination model that again was brought into being by the Blueprint for Health program, works with community health teams, and is very focused on integrating health and community services. And the care coordination model has been embedded, if you will, in the ACO payment model, and is one that is supported by the alternative payment methodology.
So, Ina, thank you so much for giving a perspective, the overview of Vermont, and just one really quick follow-up question, similar to what I asked Donna about Maryland. How, you've got these overall payment incentives, which are very strong for half the population now enrolled in the ACO, and all these different models. How does that make it down to individuals so that they wind up healthier? Like, what's the mechanism by which, all these different groups in the healthcare system, clinics, hospitals, understand, the imperative for health, not just there's some different payment mechanism?
That's a great question. And I think that the period of our work in this model, which is set in a performance period marked through our agreement with CMS, is probably not the best way to look at progress in the model, because I think that realistically, these incentives make their way throughout the state at various levels and for various groups at different times, but they are slowly flowing out to the state. And part of that, the way that they flow out, is by bringing providers to the table for innovative ideas and being able to, for lack of a better word, fund those innovative ideas because we're working in a value-based model. One example is a longitudinal care pilot, and it's really going to not be a pilot for much longer, but really shift to the program of care where persons who otherwise wouldn't be eligible for home health services, because we're working in this alternative payment space, are eligible for visiting nurses and community health workers to provide in-home services. And we've seen through this work savings in per member per month costs for these individuals. And we've seen better health outcomes, better quality of life for these individuals, reduction in emergency department and hospital admission.
Thank you. It sounds like in both Maryland and Vermont, there is the overall payment incentive that creates all kinds of different opportunities, but then the state has to take advantage of those opportunities through these different mechanisms.